Time for another entry in this series of clinical toxicology video discussions. This one is about anticholinesterase insecticides, organic phosphorus compounds, and carbamates, corresponding to Goldfrank's chapter 110. The learning objectives for this session are that you'll be able to describe the mechanism of toxicity induced by these compounds and the expected clinical signs and symptoms they produce, and, while they are quite similar, to explain the key difference between organic phosphorus compounds and the carbamates. The title of this chapter is a bit unwieldy if you ask me. A better title might have been anticholinesterase poisoning, since that describes the common mechanism. In the figure here we see how cholinergic neurotransmission works. Acetylcholine is synthesized from acetyl-CoA and choline, and it's then stored in presynaptic vesicles. It then gets released and traverses the synapse to bind to postsynaptic acetylcholine receptors. And that signal is turned off by the action of acetylcholinesterase enzymes, which cleave acetylcholine back into choline and acetate. The choline is reuptaken into the presynaptic nerve terminal, and then reacetylated and restored in vesicles and re-released, and so on. And it's this second step that gets blocked by organophosphates and carbamates, allowing acetylcholine to accumulate in the synapse and continue to overstimulate the postsynaptic neuron. Now you might have already noticed that I've used two different terms interchangeably, both organic phosphorus compounds and organophosphates. Traditionally, these compounds have been called organophosphates, and that's the way I learned it. But the authors of this chapter are being very specific in their terminology. Technically, for a compound to truly be called a phosphate, the phosphorus atom has to be linked to 4 surrounding oxygen atoms, as occurs with some, but not all, of these insecticides. So the authors instead call them organic phosphorus compounds, where the phosphorus atom is either linked to 3 oxygen atoms, or 2 oxygen atoms and 1 sulfur atom by a double bond, and the other item, noted as X, is a chemical leaving group, which might, but not necessarily, have an oxygen next to the phosphorus. The chapter's authors are undoubtedly correct, but please forgive me if I occasionally use the older terminology of organophosphates, especially because it makes abbreviating the term as OP much easier. This slide shows the chemical structures of several organophosphates, or organic phosphorus compounds. I also included some photographs from my toxicology trophy case. Most medical toxicologists I know have a collection of weird and wonderful items that their patients had been exposed to and didn't want back. These containers of malathion and diazinon are from my own toxicology trophy case collection. And that may give you an idea that, while these exposures are not very common, they are common enough that many of you will see a case in your career. And on this slide there are a few examples of carbamate insecticides. All 3 of the generic names here contain CARB, indicating that they're carbamates. Remember this from the earlier session in the course about toxidromes? Exposure to organophosphates and carbamates results in a cholinergic toxidrome, where patients get sweaty, moist, and produce lots of fluids from glandular organs where fluids may be made. They'll have GI distress and small pupils or miosis, and severe exposures can cause seizures or sudden collapse. We also went over some mnemonic devices to remember components of the cholinergic toxidrome. There's sludge syndrome, and also dumbbells, which mostly rearranges the letters from sludge, but also includes bronchospasm, bronchorrhea, and bradycardia, the killer bees. The other signs and symptoms might be noted clinically, and they might be distressing to the patient, but it's the killer bees that are the most potentially life-threatening effects. You need to breathe and oxygenate, and you need to maintain cardiac output, or the patient may die. But all of that on the previous slide was just focusing on the muscarinic or parasympathetic effects of acetylcholinesterase poisoning. If you inhibit acetylcholinesterase, you also get overstimulation at nicotinic receptors, resulting in additional sympathetic effects and overstimulation at the neuromuscular junction, which can cause muscle fasciculations, weakness, and paralysis, pretty much the same effects you'd see after a patient got succinylcholine, the depolarizing neuromuscular blocking agent. Inhibition of acetylcholinesterase by organophosphates can become irreversible through a process called aging. In the figure here in the upper left, we see the interaction of an organic phosphorus compound, OP, approaching a critical serine amino acid residue at the enzyme's active site. The oxygen in serine's hydroxyl group will at first reversibly bind to the phosphorus in the organophosphate. This inhibits acetylcholinesterase, but the enzyme is still recoverable at this point. The organophosphate could spontaneously disassociate by hydrolysis, reactivating the enzyme, but if you let it stick around long enough, the organophosphate enzyme complex can lose one of its other alkyl groups from the phosphorus, and now that particular enzyme molecule is permanently inhibited, since the organophosphate has become irreversibly covalently bound at the active site. This doesn't mean that the patient will be forever weak, but it will take longer for the body to synthesize new enzyme to replace it than to give the patient proper and early treatment to save as much acetylcholinesterase as you can before it gets taken out. For many organophosphates, the half-life of the aging process takes several hours, so earlier treatment is better. Antidotal treatment is to block the overstimulated muscarinic acetylcholine receptors and to regenerate active acetylcholinesterase enzyme. Atropine is the antimuscarinic drug most commonly recommended and used, and it's oximes that are the class of drugs used to kick the anticholinesterase insecticide out of the enzyme's active site. In the United States, the only commercially available oxime is pralidoxime, which also goes by the name 2-PAM. For pralidoxime to be effective to regenerate a given acetylcholinesterase molecule, it must be given before organophosphate aging has occurred. In the case of carbamate exposure, pralidoxime also works there to kick them out of the enzyme active site, but with carbamates there is no aging process, and even late pralidoxime will work. Atropine is given as needed, titrating to get the desired effect, which is to say, you give as much as you need to reverse the muscarinic effects, and the doses needed can be quite high. The photograph here shows the aftermath of treating an organophosphate poisoned patient with all those empty vials that used to contain atropine. But atropine or other antimuscarinic drugs will not reverse the muscle weakness, since that results from abnormal nicotinic neuromuscular junction signaling. The associated weakness is only going to respond to pralidoxime, although pralidoxime will also help to reduce muscarinic effects. Due to dysfunction of the neuromuscular junction, we can expect seriously poisoned patients during the hyperacute cholinergic crisis to be weak. But even if they were adequately treated during the acute phase, some patients can go on to develop delayed neuromuscular dysfunction or neuropathies. There is a so-called intermediate syndrome. Intermediate because it occurs between the hyperacute phase and late neurologic effects which had already been described in the literature. In the intermediate syndrome, patients who are appearing to do well go on to develop worsening weakness 24 to 96 hours after initial exposure. And the previously described late effects are an organophosphate-induced delayed neuropathy, OPIDN, which may occur many days to weeks after initial exposure. Historically, there was a major outbreak of OPIDN in the United States in the 1930s during the time of alcohol prohibition. This event is sometimes called ginger Jake or Jake leg paralysis because there was an allegedly medicinal preparation of Jamaica ginger that people would consume since it had a high alcohol content and was legally available as a medicine despite the ban on alcohol. Some preparations of ginger Jake, however, contain TOCP, an organophosphate that caused a delayed peripheral neuropathy. One of my toxicology buddies bought me a ginger Jake bottle as a birthday present. The bottle was empty though, and this is also part of my trophy case. Clinicians treating patients with anticholinesterase poisoning may order cholinesterase levels, both to confirm the diagnosis and also to help monitor the effectiveness of treatment. There are 2 cholinesterase levels you can get. Butyryl cholinesterase, also called plasma cholinesterase, is the easier assay, but the RBC cholinesterase level is thought to better reflect the degree of synaptic enzyme inhibition, which is really what we want to be treating. This penultimate slide kind of looks like a treatment algorithm, but it's more of a what to look out for algorithm in treating these patients, and this figure is taken from the textbook chapter. Feel free to pause the video and look through it more thoroughly if you're into that kind of thing. That's all I have about the organophosphates and carbamates. There's another video that focuses just on antidotal treatment with atropine and pralidoxime you'll probably want to check out too, and I'll be seeing you around.